So maybe I first introduce the first speaker, and then to see if the chair will join in the middle. Is that okay, Professor Kato?
Yes, I think so.
Yeah. So good morning, good afternoon, good evening, everyone. So welcome to the ACNS YNS webinar today. So on behalf of the Professor Kato and the ACNS Educational Committee, welcome you all to this seminar. So today may I introduce our first expert speaker, Professor Wang Hidong, who is the Professor and Chief of Neurosurgery Department of 𝑽𝒃 University Hospital in Hanoi in Vietnam. So today his topic will be how I do endoscopic third ventriculostomy and how to avoid mistakes. So may I introduce Professor Dong to share the screen?
Yeah. Do you see my screen?
Yes, it's working now. Please go ahead, Professor.
Okay, thank you very much. Dear Professor Kato and ladies and gentlemen, today I would like to share my experience how I do endoscopic third ventriculostomy and how I avoid the complication. The ETV is technique to treat hydrocephalus, everybody know, and we make a hole on the floor of the third ventricle to bypass the obstruction of the CSF flow. The first ETV is done in 1933 by Mr. And because of many reasons like the mortality is high, and we don't have enough instruments and scope, magnification, illumination, and that's why they don't use so often the ETV. But advanced with the brighter light sources and the camera, the neurosurgeons bring back the ETV techniques. And the ETV is we can do everywhere nowadays. And I have some experience to do the ETV, and that's why I would like to share my experience to the young doctors, how I learned the anatomy and how we can learn the endoscopic instruments and learn how to work with endoscopic instruments. And the third is how I can learn to make the fenestration and how I can learn to avoid the complications. And the anatomy. And the young doctor, if you would like to start to do ETV, of course, we must learn the anatomy as the other procedure. The third ventricles, we learn about the anterior and posterior wall, the roof, the floor, and the two lateral walls. And the monoforamens, we have learned the monoforamen with the septal vein, fornix, choroid plexus, the thalamus veins, and the monoforamens and the other veins. And we have to learn the floor, the anatomy of the floor of the third ventricles. We learned where is optic chiasm, infundibulum, mammillary body, and posterior perforated substance. And we can learn the recesses like infundibulum recess, optic recess. And for the second lesson is how to learn to study the endoscopic instruments and how to use these instruments. There are many kinds of endoscopic instruments for the ETV. We have learned how you scope, the trocar, And the most important in how to work together, how to work. And the young have to learn how to fix, how to work before you go to the operating room. You have to learn how to introduce the balloons, instruments, and the seesaw, everything. And I repeat, we need to practice and to practice. And how we can do the fenestrations? Of course, we have to learn, we have to study clinical assessment. We have to study MRIs before surgery. We study the third ventricle on the MRIs, the other structure, the lateral ventricle, the frontal lobe, and very, very important thing, it is the space between clivus and the basilar artery and brainstem. It is very, very important point to avoid the complications, the bleeding complication. The clinical side, of course, we study, examine the patients. And the indication for ETV. Of course, we can do the ETV for all kind of the hydrocephalus. But the non-communicating hydrocephalus, it is very, very good indication for ETV. Example, aqueductal stenosis, pineal or tectal tumors, posterior fossa tumors, idiopathic stenosis of foramen, of Magendie and Luschka. And sometimes the patient with repeated sun infections, there are some contraindication. It is not really contraindication. Maybe in this case, we can do ETV, but the result is not good like in other indication. For example, a normal floor of the third ventricle is very difficult to make a hole on the floor, or sometimes it's dangerous. Insufficient space between the basilar artery and the clivus. Insufficient enlarged third ventricle or lateral ventricle to allow to introduce the instruments in the lateral or the third ventricle. And sometimes patient with history of previous whole brain radiation, meningitis, or subarachnoid hemorrhage. It is difficult to work in the space, in the lateral in this case. And here you can see on the MRI, we can see the basilar artery. And we can see the space between the clivus and the basilar artery and brainstem. And the same, we can see the basilar artery, brainstem, we can see the space between clivus and the artery. And in this case, you can see the basilar artery here, but the space very small. In this case, dangerous. And in this case, this is a normal floor of the third ventricle because of seminoma. We can see the floor. Here you can see this small space. We can make a hole here, but here, there you can see it is a seminoma on the pineal region, and together with another location here. We can make the ETV, we can make the fenestration here, but it's very difficult and more dangerous. And another case, we can see, we can not see the floor of the third ventricle where we can make a hole. And this one, we cannot do ETV. And another exam, another patient, it's 17 boys. Yes, we have 17 years old boys. You can see we cannot find the the floor of the third ventricle where we can make a hole, we can make a fenestration. We cannot do the ETV in this case. And the technique is very simple. The patient is placed in the supine position with a small roll under the shoulder, and the head is elevated around 30 degrees, and the endoscope monitor should be directly opposite the surgeon. And we have the 6 steps for the technique of ETV. First, you determine the point, the entry point, and the enter lateral ventricle. The second, when you go inside the lateral ventricle, we must find the Monroe foramen. And the third step, inspecting the floor of the third ventricle. And the fourth step, we make a hole or enlarge the hole, the perforation. And the fifth, inspecting the pre-puncting system, and sixth one is closing. The entry point, it's easy to find the entry point. Make a burn hole 1 centimeter in front of the coronal suture and 2 or 3 centimeters lateral to the midline. Yeah, this is the entry point. Make an incision and you make a hole and you open the durometer and we pass the 14 French trocar into the lateral ventricle and introduce the endoscope to the seat. How we can find the Monroe foramen? The Monroe foramen with some anatomy. When endoscope is in lateral ventricle, we need to identify the choroid process. Sometimes, when we go inside the lateral ventricle, we can see easily the Monroe foramen, but sometimes we cannot find the Monroe foramen when we go directly in the lateral ventricles. And in this case, we identify the process choroid. And here is example. In this case, when we go inside the lateral ventricle, we can see easily the Monroe foramen. It is a very easy case. We can see, and we pass the Monroe foramen and we go to the third ventricle. But in this case, when we go inside the lateral ventricle, we cannot see the Monroe foramen because the entry point is not correctly, I think so, and the direction is not correctly when you go to the lateral ventricle, because it's not good position, and that's why we cannot see. But in this case, we follow the process choroid, and we can find the Monroe foramen. In some case, when the young have no experience, when he go inside the lateral ventricle, he cannot see the Monroe foramen, and maybe he's worried about that. But don't worry, you follow the process choroid, and you can find the Monroe foramen. When endoscope is advanced into the third ventricle, we need to identify the floor of the third ventricle. And this is some anatomy, some anatomy. You can recognize everything in the third ventricle, like mammillary body on the left side and right side. We can see the infundibulum recess. We can see optic chiasm. We can see the crevice sometimes. And sometimes we can see the basilar artery. And we need to identify the point of fenestration, the correct point is center of so-called hypophysiomamillary. How we can make the fenestration? We can use balloon probe. We can use electrocoagulation or cutting probe, laser probe, or ultrasonic contact probe. I do two methods. 20 years ago, when we don't in Vietnam, we don't have everything like endoscopic instrument for the ETV. I use a scope to make a hole. It is a little bit dangerous, but in this time we don't have enough material. We don't have everything, and that's why I use this technique. And it is easily to use endoscope to make a hole. And the instrument is very simple. We can use endoscope 30 degree. And this is one example. In that time, we don't have everything, even the scope. And now we can see everything in the floor of the third ventricle, and I can find the point of fenestration. And for the scope technique, it is a blind time. You can see it is blind time. I didn't see anything. It is very important to and I make a hole. It's done. It's very fast, but it's a little bit dangerous. Another example. It's the same thing. We can see the memory body here. You can see the infiniborum, and I make a hole in the right point. Is here, and it's fast. You can see the basilar artery. It is very fast, but a little bit dangerous. I have some advice. If you have everything like endoscopic instruments, don't use this technique. But when you don't have everything, you can use scope to make a hole. And nowadays, I use electrocoagulation probe to make a hole. And of course, it's more easily everything. We make a hole with the electrocoagulation probe. As the hole is done, its diameter is about 4 or 5 millimeters. And to make a large fenestration, I use a Fogarty balloon. It's not, yeah, you can see the balloon like that. It's I bring this Fogarty catheter from the cardiovascular surgeon. Yeah, this one is special for the ETV, but we don't have it because it's expensive, more expensive. That's why I use Fogarty. And you can make the fenestration is bigger. And we can use the forceps to make a hole, but I don't use. And that to make it bigger, I sometimes do. And this is the exam. Everybody knows it is not complicated technique, but the young have learned how to use before go to operating room. And you can find the entry point, and we make a hole, and it's easily, and we can make another hole to make it bigger, or you can use the Fogarty. I use the Fogarty. This is for the Fogarty. This is I bring this one from the cardiovascular surgeon. It's more cheap and easy to find. And the last lesson I would like to share to young, how we can avoid the complication. And this one is a little bit difficult when we make a hole with coagulation. It's a little bit difficult because the floor is very thin. You can see it. It's very thin. And this is make a hole. And I use the scope to make it bigger. It's very difficult, this one. and they take a long time to make a hole and make the hole bigger with the balloon. Sometimes it's difficult, and that's why I would like to share to young for the difficult case how you can use that. Difficult, take a long time. And this is another case when the young done the ETV and he's called me during surgery. And when I arrive in operating room, and you can see it, the young don't know how to install everything with the endoscope instruments. And that's why it's wrong in section. Yeah, you can see it. You have to make it difficult to correct in section, right? We need to avoid that. That means we need to practice before to do or to go to operating room. And this one is wrong orientation. You see it? Normally the vein is inferiously, and this one is another direction. You can see this is, and that's why it's very, very complicated. And in the end, you can see this is another one. Is you can see the my body is here. It's wrong direction. It's dangerous, and it's the bleeding. You can see it. Yeah, this one is another exam. If the young don't do the correct orientation, and it's bleeding, take a long time to everything, and he's put on the phonics, it's dangerous. To avoid complication, we need to learn how to insert correctly the instruments to the endoscopic box. We need to work correctly with endoscopic instruments, and we need to be familiar with endoscope instruments. Another complication like bradycardia, intraventricular hemorrhage, basilar artery. Sometimes the complication during opening and intranslateral ventricle is there's some minor bleeding. It's up to 16.5% because of the vein, small cortical vein, parenchymal vessel or ependymal vessel. How to control? We make a continuous irrigation. The bleeding is stopped. And this is exams. The bleedings, not it's important bleedings. You cannot find things, but keep urate, wash again. Sometimes it take 1 hour, sometimes it's 15 minutes. The bleeding will be stopped. Sometimes it's 1 hour, 30 minutes. But sometimes for the small bleeding, it's maybe 10 minutes, 5 minutes. And there are another complication during the pass-ups to the monoformans. It's bleeding from septum on Thoramos 3 event. Injury the fornix. You can see in the video when they make a wrong direction. We can see the fornix make some lesion on the fornix. The treatment is control bleeding by irrigations. To avoid, you need to learn the anatomy. At the end, just exam, you can see this is the fornix lesions because of the scope, the wrong direction, the wrong orientation, and it makes some bleeding and make some lesion on the fornix. Yeah, this is a fornix because of wrong direction. Dangerous. And there are some another complication like injury to the basilar artery. This is very important, very dangerous. So the patient may die because of bleeding. injury to the hypothalamus, injury to the third and sixth nerve, or sometimes infundibulum stroke. And this is something we have to learn before to make the procedure. When the floor of the third ventricle is thin, you can see something like that. And there are some other complications. There are many. Infection, CSF leak. And the CSF sometimes is 1.7 to 5.2%. When we have to see the CSF, especially in the young patients, to avoid, we have to block the track of the endoscopic quick film. We can see, we can make the best Gallia suture, skin suture, or maybe sometimes number puncture or dry. The infections, there are sometimes meningitis, ventriculitis, it's always associated with CSF. Sudden death because of the closure of the stoma. It's not so often. There are some delay complications such as seizure, memory impairment, or failure of the ETV. I have personally experienced 300 cases. 2 deaths because of hemorrhage, and 10 infections and CSF. The root ground is depends on the kind of hydrocephalus. It's from 60 to 85%. Therefore, there's some take-home message. You have to learn the anatomy. You have to learn and to practice to work with endoscopic instruments. And we have to training how to make the penetration. And we have to learn how to avoid the complication and to resolve the complication if they are. Thank you, everybody.
Thank you, Professor Dong. So I can see Professor 𝑵𝒔𝒂𝒏 is here, right? Professor 𝑵𝒔𝒂𝒏.
Unmute, please.
Hi, everybody.
Hi, how are you? Thank you very much.
Hi, hello, Professor 𝑵𝒔𝒂𝒏.
Hello.
Nice to see you so much. So Professor 𝑵𝒔𝒂𝒏 is the chair of today's session. He's the professor of Department of Neurosurgery at the hospital that specialties in Bosnia, University Medical Center, Rabat, and at Morocco. So, just now, Professor Dong has finished his lecture about the endoscopic ventriculostomy. So, may I invite Professor 𝑵𝒔𝒂𝒏 to introduce our discussion today to discuss about the lecture of Professor Dong. Thank you so much.
Okay, thank you. This is very excellent presentation of the how to make the ETV step by step. This is something that all young residents should learn, and the speaker really took time to explain every single step, but also how to avoid the complication. There is 2 things maybe we can discuss from the young, how we can go from a single case to a complicated case. My question is, most of the time we have a young neurosurgeon coming for the department, and we have a case for hydrocephalus. And I think the first step, he should be under the supervision of an older colleague who has this kind of knowledge. The second is that this is very important that all young neurosurgeons at the 2nd or 3rd year of residency could practice this technique, because they can avoid a lot of shunt indication. Just 2 technical points. when we are using, for example, this technique, and we have to make a CSF, aspiration, and do you use just saline, or do you prefer to use Ranger lactate? Sometimes it may be better in some situation. This is my first question. My second question: in case there is a big blooding, blood coming from the technique, I see that you try your best to arrest the bleeding from just making irrigation, but sometimes do you prefer to go very quickly to external drainage? This is my two questions.
Yeah, thank you very much for the excellent questions. The first ones, in my department, I usually use saline solution to wash off. Yeah. The second question is, you are right. I have two deaths because of hemorrhage, and I make continuous irrigation, but the bleeding didn't stop. And one is because I use the scope itself to make a penetration, and then the second one is the second ETV because it didn't work after the first ones. And when I cannot stop bleeding by irrigation, I make extended drainage. Yeah.
Okay. If there is any question from other colleagues here,
Professor Alexian, maybe shall we hear your comment?
Thank you very much. Professor Dong, thank you very much for excellent presentation, very detailed, especially for younger colleagues. Let me make some comments and some philosophy and remind something. First of all, the CSF diversion is a permanent problem of neurosurgery at any time. And reticular cysternosternmy it's a physiological procedure, so it lets us to restore the CSF flow to the normal anatomical spaces, rooms, and avoid using the shunt system, because any shunt system is not physiological. This procedure has more complications, and anytime we can avoid it, we must avoid it. I remember my residency when we performed a lot of ventricular cysternosternmy, and believe me, it worked. In pre-endoscopic era, this surgery worked very well. It was very effective and had not a lot of complications. Once we got the endoscopy, of course, the neurosurgery made a big step forward in treatment of patients with, especially of occlusive hydrocephalus. Professor Dong, you told about the choosing of entry point for the EVT, and my questions will be: do you use neuronavigation? Because in my practice, it's very important to have a navigation just for this, because the endoscope, it's a straight. You use a straight instrument, so you must have a straight trajectory to enter Monroe, foramen of Monroe, and then to see the membrane to perforate it. So if you have not, of course, it's only your experience may help you, and your 3D understanding of the anatomy of the ventricular system and the brain. And then I'd like to ask you about what do you do if you meet a small Monroe foramen? too small. How do you extend it? So what's your technique? What do you use to extend the Monroe frame? It's the first. And what do you use for irrigation when you stop bleeding? What type of saline do you use? To and wait and do you wait for stopping of this bleeding? So thank you.
Okay, thank you very much for the questions. The first question is, you're right, because sometimes for the big laterals or thirds, the big third ventricles, it is easily to find the lateral ventricles and to easily to go inside the lateral ventricle is right. In some case, if the lateral ventricle or the lateral ventricle is small, I think neural navigation is very useful for this case. We don't use systematically the neural navigation for the ETV, but sometimes if the lateral ventricle is small, I think navigation is we can use. It's correct. We can use. We use neural navigation so often for many kinds of brainstem endoscopic like pituitary adenoma, cranopharyngioma, and 𝑠𝒃𝒈 surgery, yes. But ETV is not systematically. Sometimes it's difficult to find, yes. Useful, I think. And the second one, if the Monroe foramen is too small, I think it's dangerous to pass the Monroe foramen to go inside the third ventricles. In this case, I think it's better if you stop to do ETV and we make
avoid complications.
Yeah. We make the 𝑃𝑝 is more safe for the patients. We try to pass on the small Monroe foramens. Maybe we make the bleeding from the vein, or we can put on the fornix. Is the patient will have some complication after procedure. And for the third question, the solution for WAS for irrigation, I usually use a saline solution to WAS to make irrigation when we see the bleedings. Yeah.
Thank you very much. I have some small comments. So it's there are a lot of publications, especially from Japan, where the authors demonstrate that the saline, which is maximally approximated to the CSF composition, works much better as a hemostatic agent, even much better than the regular solution. And so at least Ringer is better, would be better than the regular saline. So thank you very much. Thank you.
Yeah, thank you very much. Yeah.
Thank you. Maybe Professor Pritchett. So maybe can we hear your view on this topic?
Hello, thank you very much. This is Dr. Bijat from Afghanistan. Thank you, Professor Dang. Very nice and good presentation, and it's good for countries like Afghanistan and low and middle income countries with limited resources. It's a good way, but it's two things. One comment about if this ETV is failed, we can use the PP shunt, also the sudden hemorrhage. We can use extracranial drainage system. We do ventriculostomy and put a EVD for to drain the hemorrhages for young neurosurgeons. And the other, I'd like to ask you, that's the ETV start with cystoscope. Do we still use cystoscope for doing ETP, limited resources centers. Thank you.
Okay, thank you very much for the questions. I use the scope to make the penetrations in the first time. This is 20 years ago, when we don't have everything's like endoscopic instruments. But when we get every good instruments, we stop to use these techniques from, I think, 2006. Yeah, up to now, I use. I don't use this technique. I use coagulations probe to make a hole, and use the balloon to enlarge the fenestrations.
Thank you.
Yeah, thank you.
Thank you. Because I ask, like countries like Afghanistan, we have a neuroendoscope, and for this, sometimes it's available cystoscope with good illumination. Can we use it?
Okay.
Can you repeat your question?
Yes, I told that's and limited resources and low poor countries like Afghanistan. We have a neuroendoscope and it's available cystoscope.
Yeah.
Yes.
Yeah, thank you.
So thank you, Professor Piffet. And so if there's no further questions, so
I may say something, Ben?
Yeah. Roger,
Yeah.
go ahead.
Thank you very much, Ben. So one small thing that I would tip, like that we use here in our place is like more than 17 years of performing ETV, that sometimes this bleeding, however small it may look very alarming because we see it on a very magnified vision through the endoscope. So there are so many young neurosurgeons here, so I just wanted to let them know that bleeding is not that strong and fearsome as it appears, because you are seeing it through a very high magnified endoscope. And the best thing is that you keep on irrigating with what we here use is a lukewarm ringer lactate solution. And to test the temperature of this lukewarm ringer lactate is how much lukewarm is not damaging is one question that practical use. We usually ask that sister to pour that irrigation fluid onto our foot, right? So directly it touches the skin, so we know how warm it is. If you put it on the gloved hand, you may not accurately feel that temperature. So that is one small tip I just wanted to give. And when you irrigate constantly, you must always keep the outlet of the irrigation channel open. What happens is that when you keep on irrigating, there may be sudden expansion of the third ventricle, and it may stimulate the hypothalamus and cause bradycardia, and even sudden death can occur during ETVs. So this is one small caveat that I wanted to share with you all. Thank you very much.
Yeah, thank you very much. Yeah.
Thank you, Roger. Totally agree of your points. So if there's no further questions, so shall I invite the chair, Professor 𝑑𝒓𝒐𝒃𝒂𝒎𝒄, to introduce our second speaker, Professor 𝑘𝒂𝒄. Please unmute yourself, Professor 𝑑𝒓𝒐𝒃𝒂𝒎𝒄.
Okay. Sorry, I didn't hear you. I have a problem with the connection. So the next speaker is, I'm sorry.
Please kindly introduce Professor 𝑘𝒂𝒄.
�VM Kabulo is with us.
Yes. 𝑑𝒓𝒐𝒂𝒂𝒂𝒂𝒂𝒂𝒂. Yes, hi, from Kinshasa. Hi. May I introduce Dr. Kabulu as the next speaker, a young neurosurgical speaker. Now that in Kinshasa, Congolese colleagues are doing very good job, and now they're improving with creation of new society of neurosurgery and in RDC. And I am very happy to introduce Dr. Kabulu for his presentation to speak about the experience and of neurosurgery in Kinshasa and RDC. Please, Dr. Kabulu, please.
Thank you so much, Professor Elwabi, for the introduction. Thank you, Professor Kato, for inviting me to this meeting. So I'm going to talk about neurosurgery in Congo, Democratic Republic of Congo. I will briefly introduce my country, and I will talk about neurosurgery in Congo, how it started and now. I will be brief. I'm Kabulo, I'm a neurosurgeon, and currently I'm fellow in cerebrovascular at Fujita Health University, Bantane Hospital, under Professor Kato. So Congo is there in Central Africa, is the second biggest country in Africa after Algeria. So this is the surface area. Then in terms of population, we are the fourth. The first one is Nigeria, then Ethiopia, Egypt, then Congo with more than 95 million population. The capital city is Kinshasa. Kinshasa is just opposite to this picture. I took it from my hotel in Kinshasa. The other side, you can see it's Brazzaville, the other Congo. So it's just the Congo River, which is separating the two capital cities. These are the two closest capital cities in the world. Then Congo has 26 provinces, and I'm coming from this province called Okatanga. The official language is French, of course, then 4 national languages and more than 45 dialects, 450 dialects. So this is my town, Lubumbashi, and Congo was colonized by Belgium, and we got our independence on the 30th June 1960. So far after independence, we have 5 presidents. This is the current one on the right. Our main food, it depends on the location where you are. Like those who are in Kinshasa, they eat this nkwanga. East, they eat rice. We eat mainly fufu, ugali, pap. And the main vegetables, we are eating cassava leaves. This is the university where I did my undergrad. Then my postgrad, I did it in Zimbabwe, University of Zimbabwe, under Professor Kalangu. So how it started, I will just talk about the pioneer of neurosurgery in Congo. This is Professor Shako Junga, who was born in 1938, and he graduated from the Free University of Brussels, where he did his medical school. Then later he trained in neurosurgery. After that, he completed his fellowship in New York, and he came back to Kinshasa, and he only worked for few years. So that was very difficult stage, because he didn't have much things to use instrument, and unfortunately he died on age of 48, leaving like a void in neurosurgery. So this was at that moment Dr. Belchika, who was a young general practitioner who was working with Professor Shako. After the passing on of Professor Shako, Dr. Belchika went to France, and he did his neurosurgery and graduated in 1987. So this was the only neurosurgeon in the country from 1987 up to 2008, when others started to come. You see how neurosurgery is still a young discipline, or a new discipline in Congo. It's only in 1988 when Professor Dr. Belchika came back, where we acquired the first CT scan machine, and the first MRI machine came in Congo in 2014. So these are the local neurosurgeons. We have 19 local neurosurgeons. This is Professor Ntambi, who is the director of neurosurgical training program in Kinshasa. He also came to Japan under Professor Takizawa. He did the neurovascular. And Dr. Ntalaja, who is a young and hot blood, trying to push for our neurosurgery to go ahead. So we have also 3 neurosurgeons who are Congolese, but they are working outside. They are from the diaspora. They are coming to help us, Professor Kalangu, Professor Kalala, and Dr. Makiese. So if you see, this is my country, and before 2013, neurosurgery was being practiced only in Kinshasa. And after 2013, in Kinshasa, in my town, Lubumbashi, and in Bukavu. Soon in Kisangani also. So with those 19 neurosurgeons, we have 10 in Kinshasa, 7 in Lubumbashi, and 2 in Bukavu for 95 million population. So it is still a small number, and we need to add more neurosurgeons. So we have a Society of Neurosurgery, which was created in November 2015. Then in 2019, our brothers from Congo Brazzaville joined, so we are forming like one Society of Neurosurgery. Like Einstein said, once you stop to learn, you start to die. And if you learn something new today, your future brain will thank you. That's why our perspective are to develop a sub-unit of neurosurgery by pushing young to go and do fellowships like we are doing now in different subspecialties. It will help the neurosurgery to go ahead. And then we still have other young who are in training, like in Senegal, Morocco, Europe, and in Kinshasa, we have a school of neurosurgery with 7 residents, and also soon Lubumbashi will start. The Congolese Society of Neurosurgery, sometimes we do humanitarian missions where we go town by town, we operate children with hydrocephalus, and so far we have operated 1,000 of those kids. We are also organizing some conferences, like last June, we organized WFNS Spine Committee basic courses in Kinshasa. These are the pictures with Professor 𝐿𝒑𝒑, who was our guest. So challenges we are facing, there are many challenges. I will just try to summarize. Lack of access to equipment. We have a limited number of training programs, and also we don't have basic neuroimaging. We don't have neuro anesthetists. We don't have neuro nurses. And also there are a huge list there. If you see limited resources, limited on research, because research need funding, and also access to microsurgery training, which is also difficult, and also equipment. That's why sometimes, like in my country, this is the only center which has microscope. Every time you have a huge case, a big case you want to do, you have to move the patient to that hospital, which is also costly. For poor population, they can't afford that. Late referral of patients. Sometimes small health centers are keeping patients for neurosurgery instead of transferring them to the facilities where they can take them. Then poverty is also one of the challenges, and wrong belief. People are still like, oh, they don't operate the brain, they don't operate the spinal cord. If they operate, you will be wheelchair bounded, something like that. So we still need to advertise, to do some sessions to tell people like, we can now do it. This is my hospital in Lubumbashi, which was recently renovated. And that hospital, I don't have a neuro nurse. I don't have a neuro anesthetist. I'm just using the general anesthetist to do cases. And that big hospital, it's a provincial hospital. There are no imaging modalities. We don't have a CT scan, MRI scan. All patients who are coming, we are sending them to private hospitals to do that. Like we send them here, patients who need to be operated, like when you want to do rods and screws or ACDF, we have to take them to private hospitals to do that. How rich the country is, but still behind, because neurosurgery is also a young discipline. This is our biggest forest, equatorial forest in Congo, very rich in natural resources, but the war sometimes is keeping us behind. We have some species where you can only find in Congo, bonobo and okapi. those species are only in Congo. We have our almighty Congo River. This river, the place where it is draining water in the ocean, you can still recognize it water up to 40 kilometers in the ocean. We have also that volcano Nyiragongo in Goma, which is the biggest one. Now, what to say in conclusion? Neurosurgery is a new discipline in Congo, and we are facing many challenges. But in the last decade, we tried to move. We now managed to get things, because in Kinshasa we can do now endoscopic surgeries. We can, they are sometimes calling surgeons from outside to come and clip aneurysms, which is a big development. And we are looking for collaborations with other countries, other associations, for donations of equipment for us to go ahead. Then young neurosurgeons are encouraged to do subspecialty like we are doing. And we thank you so much, Kato Sensei, because she is contributing already to those challenges. She's training me in neurovascular. She's also training, the one behind me is a nurse. So he came to do nursing in neurosurgery. So we'll at least have one neuro nurse in Congo. Thank you so much to Professor Kato for that huge help to Congo. Not only Congo, it's all Africa, and what you are doing to the whole world. So this is, we are having our CANS meeting in Kinshasa, November 2024. So we welcome you to Kinshasa, and arigato gozaimasu.
Thank you very much. Thank you very much, Dr. Gula, for this very young, very nice presentation on the history and the development of neurosurgery and RDC. And it is for me also occasion to thank Professor Yuko Kato for the enormous and continuous effort she is doing in Africa to help neurosurgeon, young neurosurgeon, to develop many subspecialty, and particularly vascular surgery, but not only in sub-Sahara, because she was with us for the last 10 years for developing other things like endoscopy and also epilepsy surgery. And so thank you very much. And this is for me the opportunity to thank her another time. Now, I would ask also to add that our colleague, Dr. Kabulo from Lubumbashi, as co-chair of the Young Neurosurgeon Forum from the CANS, the African Federation of Neurosurgery. And the group of RDC is very active. We just organize meeting, and you can see a WFNS spine meeting, and they are now preparing for in the next year to hosting the CANS, the Continental Association of Neurosurgical Surgery, with a big event. And you are all, of course, invited to help them by your experience, your expertise to be there. It's very important that a country like RDC, what's with like almost 100 million inhabitants, be the center of this area to promote neurosurgery. So this is my comment. Thank you, Dr. Kumra, for your presentation.
Thank you, Professor.
So maybe Professor Preset, maybe can you share your experience as well? Professor Preset? Maybe he's not here at the moment. So maybe Professor Allison, so any comments?
Ben, thank you very much. Dr. Kabulo, thank you very much for excellent presentation. Actually, you painted all the picture of situation in your country. It's a quite tough situation, really, because your country is about 100 million population, requires at least 1,000 neurosurgeons according to modern recommendations, but you have only 19. So yeah, you are on the beginning of the big way, and in this situation, I think the only your personal activity and activity of your colleagues, your enthusiasm are the leading factors in developing of your neurosurgery. Step by step, you will be more and more recognized by your government, by your officials, and finally they will understand that if they will support neurosurgery in the country, it will be profitable for them politically, for their advertisement, to show that they buy some, if they will buy some equipment for you, they will demonstrate it on the TV and the radio that they buy this. So you must go this way to be recognized, to be noticeable, and to be how to say, to be profitable for your politicians. So maybe it's a little bit not simple, but this is a way to move forward. And another side of your activity to develop your relations with the foreign organization, what you do, what it really do, and you're on the correct way. So I wish you the best. I wish you prosperity. I wish your neurosurgical service be more and more effective and to bring more profit to your people. So thank you once more.
Thank you so much, Professor.
And Professor Kabul, I also want to congratulate for your hard work and showing full support to your concept and also your idea about the subspecialization. So from your lecture, I can see the difficulties that you have now. And I really hope that you get through all those difficulties and gradually build up the neurosurgery society in the Congo. So all the best to you and your country.
Thank you so much, Sensei.
So maybe if there is no further questions, so shall we go to our third presentation by Professor Țăngeva. So maybe shall I invite Professor Țăngeva? Oh, Professor Țăngeva, you have something to say?
Yes, thank you very much. Thank you, Professor Kabul. That I like just say that we have the same level, and Afghanistan is the same challenges, the same problem, and the poor condition in Afghanistan. Don't worry, and we can communicate with you and share our experience. And you are a bit better level because in our country is also the our condition is just complicated and difficult because of political issue of our government, and the otherwise we are the same. Thank you very much. Thank you.
Thank you, Professor. Thank you.
Okay, I now ask our next expert speaker, Professor Țăngeva. Professor Țăngeva is a consultant neurosurgeon for skull-base surgery. He is the skull-base surgery lead at Oxford University Hospitals, and he will explain today and present his thought about the anatomical consideration for skull-base surgery. Thank you. Thank you.
Thank you very much. Thank you for the invitation. It's always a real pleasure to be here at the ACNS. Always very good talks. Before my talk, I'll just say I was really impressed by that last talk. We also have 19 neurosurgeons in Oxford, but we only treat 3.5 million, and you're treating 95 million. And we think we're working hard. So clearly, it's very, very impressive. I really like the bit where you're going in. You treat about 1,000 patients with shunts going around the country. Oxford has a global neurosurgery program, but I don't think we've ever taken, global surgery program, but I don't think we've ever taken neurosurgeons. So if anyone from Congo or anywhere else is interested, the ACNS has my email. So just drop me an email. We'd be very happy to help and if we can, to train people. So please let me know.
Thank you. Yeah.
Okay.
Yes.
Now on to my talk. So I had a very broad had a very broad topic, which I'll try and hone down, which was anatomical considerations, skull-base surgery. And I know it's only 15 minutes, and I will keep to time. So I think I understand there's going to be a broad range of skills here and people listening to the webinar. So really, I'm going to talk about anatomy and planning, and then in the executing of skull-base operations. I'm going to use the posterior fossa as an example and sort of move on to the petrous apex and talk about how we use anatomy to understand the complexity of those areas. Obviously, we're very lucky at Oxford, a lot of technology available. I'll talk a little bit about that as well. Okay, so if you're a skull-base surgeon, these are the sort of things you have to be able to deal with. So top right pictures are obviously petrous, large petrous meningiomas, very vascular acoustic at the bottom. Bottom middle is a true petroclival, medial to the trigeminal nerve with PL involvement of the brainstem. And then on the right, here's a chordoma involving both cavernous sinuses and the basilar. So these are all cases that we've operated on and where anatomy is very, very useful. But I think today I'm going to focus more on slightly more simple tumors involving the petrous apex. But let's start with the posterior fossa. The Roton collection is an amazing resource. I'm sure everybody's using it. If you're not, you must. I still use it now. And for teaching, it's amazing. And of course, it's freely available. So let's talk about the anatomy of the posterior fossa and what you need to understand broadly when you're operating here. So it's sort of cone-shaped, broader at the top and then narrows down. And how you get there, well, there are different approaches. That's what I'm going to talk about today, the sort of anterior petrosectomies or Kawase. Probably the one everybody will use the most, including us, is the retrosigmoid. That's the true workhorse. And as we talk through the four major approaches here, you can see why the retrosigmoid is the workhorse, because it gives you a panoramic view into the posterior fossa. Okay, so from the tentorium or even above, if you use it to drill the petrous apex or to cut the tentorium, you can go above with the retrosig all the way down to foramen magnum. So that's the real workhorse approach. If you learn one approach, it has to be that one. Today, I'm going to talk a little bit about the drilling out the sort of anterior petrous apex there. And that you have to understand has its limitations. And I've sort of shown what you sort of get with it. You can get to the level of the IAM, probably a little bit below it. But if you're going to go a lot lower, you want to look for something else, I think. And I've shown it going slightly beyond the IAM. You can do pre-meatal or post-meatal drilling. Obviously, if you're going to go very low down, it's a far lateral for the foramen magnum. And then this is an approach I've spoken about a few times, possibly here as well, that I really like. And that's where you do anterior and posterior petrosectomies. You cut the tent, you combine them with the retrosig, and that gives you fantastic access into the posterior fossa. All right, so these are the sort of approaches we would use in Oxford. By far, the most common thing we use is retrosigmoid, but you have to be able to do all of them. And of course, there are endoscopic approaches as well. When you're planning this, what are you looking for when it comes to the anatomy? So very, very lucky, we get very advanced imaging. I won't talk about it today, but we're getting even more advanced CT technology now, like photon counting CT that's giving us great resolution with perforators and in the bone. But this is the sort of thing when you're planning the approach, particularly on the left-hand side, you're very interested in the draining veins involving the speech areas and what you're crossing and what you may or may not be taking in some of these approaches. You can go into great detail into the bone when you're first starting out. It's just about, and I'll talk about this as I show some anatomy. You initially may possibly look at what your access corridor and how pneumatized it is, but as you get more advanced, you'll start to work out how many millimeters away you are from drilling out the labyrinth or the cochlea, or the IAM and things in these sort of petrous bone approaches. And of course, bone invasion will change that and can make the bone more hyperostotic. And finally, the patient's hearing is very important to us because we want to know we're going to use a hearing preservation approach, even if we're going with a complex petrosectomy. If they've got good hearing, we'll go, retrolabyrinth, for example, rather than translabyrinth. And definitely in an anterior petrosectomy, you want to protect the cochlea. Okay, so that's some of the basics. positioning. And the incision, you can do it through very small incisions, or as I've shown here, through a large incision. I don't think it really matters. The choice is yours. If you're going to do what I'm going to focus on today, and that's the sort of petrous apex, positioning is really important. And I think you have to understand what you can alter during an operation and what you can't alter. Depending on the operating tables you have, with modern tables, you can really rotate. But even then, I think, the start is nice to get an optimal position. And just tilting the head upwards for an anterior petrosectomy is helpful. It just brings that petrous apex slightly closer to you when you're drilling. And for most of this, you want to laterally flex the head. It's a retrosigmoid that really opens up that space for you. If you're going subtemporal, it just helps with the temporal lobe falling away using gravity. You can use a large incision like this. You can use smaller incisions focused on the temporal lobe. That's a personal choice. Once you get in there, you have to understand that every little step matters. So positioning really matters. The craniotomy really matters. And usually it's hard to cut right down to the floor, but you do your sort of standard craniotomy, and then it doesn't matter how far away you are, you must then drill to get flush to the floor if you go any sort of subtemporal approach. I think that's really important in minimizing the retraction on the brain. So getting really flush on the floor is very, very important, and we would do that every single time. Your next steps in using anatomy to help you, and in this case, again, we're talking about anterior petrosectomy, is picking up the middle meningeal artery and the trigeminal nerve. And middle meningeal is very easy to pick up. You can follow it on the surface of the dura and follow it down, and you have to understand the relationship to the trigeminal nerve, which is anteromedial to the middle meningeal artery. And I'll show a brief video where you pick it up and then move on to the trigeminal. Now, I think if you learn one thing today from this talk as a skull-base surgeon, understanding the trigeminal nerve here in the middle fossa and understanding the layers of dura, and I'll show the next pictures on that. The layers of dura on the trigeminal nerve is the one bit of anatomy that, if you're already doing a lot of these sort of meningiomas and things and you want to sort of move forward, one big step you can take is really understanding how to separate the true dura of the temporal lobe off the trigeminal nerve. And that really opens up this whole area, this whole petrous apex and cavernous sinus to you as a surgeon. Okay, so we're talking about lifting off, I'll show a picture in a minute, the dura of the temporal lobe off this layer here of the trigeminal nerve. You'll understand that you must also pick up GSPN. So you've got the middle meningeal, anteromedial of the trigeminal nerve, and GSPN there. For the surgeons who are more advanced, you'll understand that the trigeminal nerve sits in a trigeminal depression here. You can sort of make that out here. And that's the true petrous apex that you must drill. And by drilling ovale, opening up ovale, taking the nerve forward, that really opens that petrous apex up to you. This is just a very, very basic, very small trigeminal schwannoma. You get nice complete resections just by understanding these layers of the trigeminal nerve. And that was described very nicely by a number of surgeons. This is a paper by Professor Kawase that I think had some really nice pictures in it, showing that you have the periostral dura. You have this dura along the trigeminal nerve, and that is separate and can be very easily dissected off the true dura propria dura of the temporal lobe. Okay, so this is really, really important to understand how you get a sharp instrument in here, separate those layers of dura, and shown in picture C here, you can start to lift the temporal lobe and expose the entire cavernous sinus. So it gives you great access to cavernous sinus, but really important step in accessing the petrous apex. So I think if you take one thing away, as a skull-base surgeon, you should really spend time learning these layers of dura. At V3, it's very straightforward to separate it. You can do it at V2, you can do it at suborbital fissure, but at V3 is very straightforward. And that gives you huge access to this entire region. Really, really important bit of anatomy. Okay. And once you sort of lifted off the temporal lobe, again, beautiful roton picture here showing the area you're interested in drilling. So just to orientate you, trigeminal nerve, V3, IAM, which you're going to protect in the drilling, cochlea, which you're going to protect in the drilling, and the labyrinth. Okay, and then you've got GSPN, which is a landmark for the horizontal carotid there, and obviously in the brainstem. This is the area you're going to drill. I'll show it again in another picture. If you're more advanced, you're going to drill deeper. You must remember where the sixth nerve is going to be as you're drilling. But this is your target. The safe area when you're starting out is to drill, to start deeper. You may have a dehisced carotid, as in this one, which actually I think makes it easier. And then you're going to work towards cochlea, IAM. You'll lift the trigeminal forward to get the true petrous apex and the carotid. We're very lucky. As I said, we have a lot of technology, not just in the operating, but even before. Huge ability, various bits of software to generate 3D pictures from real patient imaging, which we find very, very helpful in our surgical planning, and to be able to rotate these pictures in 3D, incredibly helpful to us. Just another roton view there of the area and why that anatomy is really important to understand. This picture is very useful. It's a slightly different view. This is the drilled petrous apex, cochlea there, geniculate going with GSPN and the carotid, and it highlights a few important things. So again, the safe area to start is deep and to come back, but as you widen the corridor, you will drill back towards the carotid. Very important to understand that. Very important to understand that you can drill right towards 6 and where it's going to be, and also sort of things like the dorsal meningeal artery that can supply tumors in that location. The critical structure, of course, is fourth. In a lot of these tumors, you'll cut the tentorium. I'll show the fourth nerve in an operative video. I think in smaller tumors, you must protect the fourth. It's harder in large I find it more difficult protecting in large petroclival meningiomas. So just have a look at how I'm doing for time. So this is a chordoma, and you can see how these wrap around the carotid, and really having a view of how this turns around carotid. Again, that 3D planning preoperatively is hugely important. This is the anterior view, that's the lateral view, superimposed onto the preoperative imaging. I think in the interest of time, I'll skip this video and just go on to the next one. So there's a very straightforward small petrous apex meningioma that you could do through a retrosigmoid. I think that's not unreasonable, but we chose to come via an anterior petrosectomy. And again, we find the preoperative planning extremely useful. You don't have to use image guidance during the operation, but we find this hugely beneficial, definitely in terms of preoperative planning. Mark out the carotid, tentorium, cochlea, all the things we want to protect, the porus acousticus and its nerves, the cochlea, and the tumor. So we find this incredibly helpful preoperatively. Okay, so right-sided approach. Just play the video. This is anterior, this is posterior, and we're going subtemporal. So heading down towards picking up middle meningeal. And you're going to coagulate that, and then we know that trigeminal is going to be anteromedial to that. It's a very short video because of the interest of time, but I'm separating between the layers here. I don't show it in very much detail, but it's a very straightforward maneuver. I'm just lifting with a dura. I'm going to separate more. As I said, you can use facial nerve monitor there. As I said, if you just take one thing away from this ability to lift the temporal lobe, here where you're doing a sharp dissection, that's trigeminal with some tumor in Meckel's cave, a bit of tumor there in Meckel's cave. But this ability to lift the temporal lobe off the trigeminal nerve, I think, is hugely useful if you just take one thing away. If you're a surgeon who's sort of getting into doing these sort of approaches. So drilling starts deep, then you start to widen it out. It just gives you very, very nice access. I've made the video very short, so I know it's a 15-minute talk. So I start deep. I'm going to drill out towards IAM, cochlea, then go forward towards the carotid, and skletonize all of that. You can open just infratentorial, but the standard opening would be supratentorial, infratentorial, and coagulated tent. So that's the tumor there, still attached to the tentorium. We use an ultrasonic aspirator. I'm a big fan in debulking. I almost never take anything on block. Just cutting out some chunks of the tumor. More debulking just to peel it down. Even in a small tumor, it makes the anatomy much, much easier to see. Fourth nerve is that's the top there, the brainstem. Fourth nerve is there. Quite stuck in this case. Normally, we just like to lift off the arachnoid. It's quite stuck. So we're just going to sharp dissect the arachnoid off. Fourth nerve obviously should be intact in a small tumor like this, both anatomically and functionally. And that's just a tumor coming downwards, still attached to tentorium. It's going forward into Meckel's cave. Getting the posterior limit of the tumor there. We're going to push it forward. See the major vessels deep to it. So just taking all of the back of the tumor off. We prefer arachnoidal dissection, but here it was very, very stuck. So we had to cut the arachnoid there. And that'll be the anterior component, small bit of Meckel's cave, all of that coming out. Very tough tumor. Normally we just sort of lift out, we debulked it, and that's the final view. So tumor's all out, coagulated, tentorial edge there. So you can see we've drilled just enough. Could have taken a bit more of that hyperostosis. Nice low craniotomy, fat there. That's the fat there. I'm sorry, she's moved on that post-op scan. Tiny amount of blood, but tumor's out. Okay, so I think that's most of what I wanted to talk about. So thank you very much again for this opportunity. Just an example of how anatomy can be very useful in what I think people think may be complex approaches, but actually are not. They're relatively straightforward things to do.
Professor 𝐴𝒃𝒊, please unmute yourself.
Thank you, Professor Sanjeeva, for this excellent presentation about the anatomical and also your experience regarding the skull-based tumors. I have two comments. You know that today there are a lot of patients with the small tumors that are of skull-based tumor that are not operated, just sent to our colleague for gamma knife. And sometimes we have this discussion, especially for the tumor that are not very big. What is your argument to explain to the patient to go for surgery instead of going for gamma knife? This is my first comment. My second comment is now there are many young neurosurgeons are training either in cadaveric dissection or sometimes in simulation or both. This is, in my opinion, very good. Especially, we need to go from cadaveric dissection because it's fundamental to have this. But all this cadaveric dissection are dealing with normal anatomical advancement. What about when you are in the operating room? You have the pathology anatomy that should also learn in operative theater. What's your opinion about that?
So I agree with both of your statements. So we use LINAC, similar to gamma knife, but we've chosen to use the LINAC. We use it a lot, and I am the neurosurgeon who sits on that panel every week, and we treat. And we give all patients a choice. So, this tumor was growing. We wouldn't operate on a small tumor that was not growing asymptomatic. Tumor was growing, patient had trigeminal symptoms. And on that basis, overall, we decided on surgery. But a lot of our patients go for radiosurgery. It's an excellent treatment. We have 95% control rates at 10 years, 90% at 15 years. But equally, surgery is a good option, and we offer it to all patients, and we discuss the pros and cons. And if they want, they can have an appointment with the radiation oncologists to discuss it. So excellent treatment, but surgery definitely has its place, as we did in this case, and certainly on almost all of the other cases I showed, which are very large tumors, all of those were operated on. and obviously we follow up with radiotherapy when needed. That's the first thing. Second thing, I agree 100%. I think cadaveric dissection is the most useful thing you can do as a neurosurgeon, as a skull-based surgeon. You must do it. You're quite right. It's very different. Probably the classic example is sphenoorbital meningiomas, where the bone is completely different to drilling a normal orbit. But if you don't drill the normal orbit and go in and understand, you have no chance. Because sphenoorbital meningioma in any when there's a tumor there. So you must, any opportunity you get, you must do cadaveric, definitely. And otherwise you have no chance when the anatomy is abnormal. But simulation is useful. I don't think it's as good as cadaveric. You know, we have cadaveric courses in our university and I teach on a lot of them. But you can't do that every day and you can't do it for every case, for us anyway. Some people maybe can. And for that, we really enjoy these 3D simulations, and certainly our residents find it very, very helpful. So that's my view on that.
Professor Alexander, do you want to comment on the skull base anatomy as mentioned by Professor Sanjeev?
Thank you very great experience. Let me comment a little, maybe a little extend the topic. I'd like to start, and I completely agree with Professor Abdus-Samad that real surgery and anatomy is quite a different thing, but anyway, they are connected, and it's a really stepwise process. So we start from normal anatomy, and Roton Atlas all Roton illustration are presented in projections, no projections. You must know project of real surgery, and in this term, I'd recommend the Hakuba and Fukushima. After Roton, the next I'd recommend to study Hakuba Atlas, and I like it very much. It's Hakuba and Fukushima. This is the next step for understanding of the syncope, because the syncope, understanding of pathologic anatomy and knowing this understanding of syncope with the vessels and nerves is the I think it's crucial in planning of approach and in planning of radicalism of the surgery. For example, the same tumor on MRI in the CP angle could be petroclival, could be petrous apex, and could be tentorial notch meningioma. It's on the MRI with almost the same, but the syncope with the fifth nerve root, with the seven, with all other anatomical structure will be absolutely different. It's very, and using of preoperative reconstruction, of course, it's very, very, very helpful. And the last step, not last, but the next steps, of course, is the dissection. Only real dissection may give to the trainees, to young neurosurgeon, the understanding, the feeling of a real anatomy of the brainstem. And of course, the last step, it's a hard work in the OR. Many, many hours in the real surgery with the chief, with the mentor, and then by yourself, step by step. It's a way of skull-based surgeon. And so this is my comment, and actually I have no question because really very clear presentation, and thank you very much again for information and for videos you demonstrate. Thank you.
Thank you. I think you make a really good point. I like, well, I don't know if I consider it a joke, but I like to tell the residents that, you know, going to cadaveric lab is a bit like being in a swimming pool, and you know, when it's all bleeding in the operation, you're in the ocean now, and the waves and crashing on you, and it's different. But you have to start somewhere.
Yes.
Professor 𝒌𝒆𝒃, you want to say something?
Okay, thank you, Professor Sanjeeva. It's excellent presentation and it's step by step and but good learning purpose. And I agree with Professor Abdesamad. It's the normal cadaver and the pathologic is different, but you explained very well. Thank you very much, and we like to someday do scalp-based surgery as well in Afghanistan. Thank you very much.
Yeah, absolutely.
And Professor Sanjeeva, I also want to thank you for giving us the good anatomy lecture. I think I remember I attend a workshop in Bristol a few years ago, and in your workshop, and I really learned so much from you. And also lectures from when you come to Hong Kong, and I really enjoy it. Thank you so much. So another concept that I want to supplement is about the wound opening. So I think for young neurosurgeons, so what they practice on the cadaver, they also need to focus on the about the different layers of for the scalp incision, especially for scalp-based meningioma. For example, to study well about the interfascial dissection. In that way, you'll get the temporal fascia later on for repair, say in compact petrosal, and that's very important technique for a young neurosurgeon as well.
Yeah, absolutely, I agree.
Thank you so much. So may I invite our chair to introduce the last speaker of today's section?
Okay, our last expert speaker is Professor Hidehito Kimura. He's professor of neurosurgery at Kobe University, and he will present his experience on basics and tips for bypass surgery. Thank you. Thank you.
Kimura Sensei, please your screen.
Yeah, thank you. Just a moment. Sorry, what problem? Can you see my slide?
Yes.
Okay, thank you. I'm sorry for my delay because I had changed my laptop computer last week, so the condition has been changed somewhere. So I'm Hidehito Kimura working at Kobe University. I'm very honored and pleasure to having me here, and deeply appreciate Professor Yoko Kato and Ben and Roger and Dr. Liu and Chairman. Thank you. And so today's my topic is basics and tips or bypass surgery. So I'm my university hospital located at Kobe City, and the Bantan Hospital in Nagoya located here. So don't forget, if you visit Bantan Hospital, contact me prior to that. Okay, anytime. And today my topic is ST-MC anastomosis. It's very familiar technique to anastomosis the superficial temporal artery to the middle cerebral artery branch like this. And how to harvest the STA, how to anastomose, very important technique for all neurosurgeons. So today's my content here and the indication and the clinical evidence and the principles in the actual surgery. And finally, talk about the training. So, as regards with the indication, so ST-MC anastomosis can be performed to these kind of diseases: ischemic stroke and Moyamoya disease and complex aneurysm. If you want radical resection of the scalp-based tumor presented, you should perform the ST-MC anastomosis or something like some patient we have to choose the high flow bypass prior to the obstruction of the parent artery, major parent artery. So today's main topic is ischemic stroke and Moyamoya disease. And as you know, there are two randomized, prominent North American randomized trials failed to show, unfortunately, the superiority of the surgery over the medical management. But you know, there are two randomized trials have the great major complication during the perioperative period within the 30 days, within the 30 postoperative day. The high frequency of the postoperative morbidity. So due to this morbidity, the randomized trials could not reveal the clinical significance between the surgical group and the non-surgical group. However, later on, we several kinds of randomized trials have been shown to show the improved cerebral hemodynamics and the clinical efficacy was shown. One of them, we Japanese have the JET study, Japanese ECIC bypass trial. Clinically, it demonstrated the clinical efficacy for the patient with ischemic disease and suffering from ischemic disease. We performed the SDMC anastomosis to this patient. The clinically effective, the outcome was good. So inclusion criteria was shown here. In the patient with internal carotid artery and middle cerebral artery stenosis or occlusion suffered, and the patient suffered a recent transient ischemic attack or minor infarction. So the patient kept the minor disability, the modified Rankin scale less than 2. Much more disability, patient may be wheelchair is not a good indication for this surgery. And if you can perform the cerebral blood flow study using a SPECT study, is better for you to check the indication of this surgery. So this is a well-known IMP SPECT study, is a unrest study and the diamox activated study here. And you know the unrest, even on the rest state, and the patient suffered ischemic severely disturbed the left hemisphere, and the diamox injected the cerebral blood flow was more decreased. Is a good candidate for this patient for the surgery. So quantitative evaluation shows that if the patient have the ipsilateral CBF decreased less than 80%, and the cerebral battery activity was less than 10%, is a good candidate for the bypass surgery. But if you don't have the SPECT study, you can choose the patient if the patient is progressing stroke, and if the patient has a IC occlusion, severe IC stenosis, or MCA severe stenosis, and the patient suffered a progressive stroke, and the day of the next day of the admission, if the patient progressed the disability, hemiplegic disability progress, the patient can be a good candidate for the emergency surgery of the SDMC bypass. But if you have chance to perform the SPECT study, you can evaluate the patient accurately like this. And this JET study was proved the efficacy clinically statistically significant. The 206 patients were included, and 103 surgical group, and 103 done with the best medical treatment. And the primary endpoint, the surgical group was only 7 patients, and best medical treatment group, 70 patients achieved to the primary endpoint, complete stroke or death, something like that. And this difference was statistically significant. And also, the secondary endpoint was ipsilateral cerebral infarction recurrence. And the surgical group, only 3 patients recurred in the ipsilateral cerebral infarction, whereas their best medical treatment group, 11 patients suffered the ipsilateral cerebral infarction within the 2 years. And you can see the difference is statistically different. So the patients can be selected appropriately and this surgery can be justified, you should perform the patient to avoid the deterioration. What is important is no perioperative major complication. Okay, no perioperative major complication. You should perform the bypass successfully and within less cramping time. Very important. Another study was shown recently. Professor Kuroda shown the efficacy of the STMCM anastomosis with a double barrel anastomosis. The patient, the surgical group, the patient suffered 0.7% per year with an ipsilateral cerebral infarction, whereas the best medical treatment group, the patient 60.5% per year suffered the recurrence with an ipsilateral cerebral infarction. So that the difference was statistically significant. So in this study also proved the efficacy of the STMC anastomosis to the chronic atherosclerotic disease patients with a minor stroke patient. So what is important is to know the principle of the bypass surgery. Here I show the three principles. Of course, the temporary cramp time of the M4 portion as short as possible. Within usually it took about 20 minutes, but if some bleeding, some decramping of the accidentally intraoperatively, it may occur, but it takes about 30 minutes or something like that. But maybe sometimes it's okay. But it's preferable less than 20% is more preferable. And don't pinch the intima directly. Don't pinch the intima directly. Grasp the intima directly. Here, if you grasp the intima directly with the forceps, and the intima was injured, and the platelet aggregation will be occurred. And let intima making eversion like this and facing each other. This is a very preferable condition. If you insert the needle far away from the edge like this, the ventricle was inverted, and here the platelet aggregation may occur postoperatively. The anastomosis will be occluded. So to avoid this occasion, needle insertion very close to the edge, very important to making the eversion. So I talk about in actual surgery. So usually I doing the double barrel anastomosis, but in some patients you can choose the single anastomosis. You can see the parietal branch STA and frontal branch of STA. Both grafts are usually available for this surgery. But if you use the single anastomosis, you just make a skin incision, linear skin incision just above the temporal STA. And relatively small craniotomy, you can find out the good recipient. And if you perform the double barrel anastomosis for the ischemic stroke patient and moyamoya disease patient, that I differ two diseases. For the ischemic stroke patient atherosclerotic disease, I make just a two linear skin incision just above the both ST grafts. Important point is connect these two skin incisions did not connect each other. I have some space, some interval between two skin incisions to avoid the postoperative necrotic complication. So the moyamoya disease, I make a for the moyamoya disease, I make a large covering skin incision to make a relatively large craniotomy to establish the indirect revascularization. As you know, that after the direct anastomosis and the temporal lobe and the pericranium and the first year was covered over the brain to expect the further revascularization as an indirect revascularization. And for the ischemic patient in a relatively illustrative case in 65-year-old male suffered a transient distal 3-year and left mild hemoptysis. He suffered a diabetes mellitus and hypertension. The diffusion weight image showing the small scattered right frontal parietal region. And you can see the right ICA was severely occluded, severely stenosed. And the SPECT study demonstrated severely disturbed right side cerebral blood flow. And the quantitative evaluation demonstrated ipsilateral CBF was less than 80%, and cerebral bus reactivity was less than 10%. It was a good candidate for the STMs in the CNS mouse. In the patient was down with an emergency surgery. In some situations, I have to choose a single osmosis. So that single osmosis is very, very, very simple technique. Just making a linear skin incision over the parietal branch of STA. And I use the microscope in harvesting the parietal branch of STA. Now I'm using the so-called bipolar cutting method. Professor Takizawa also performing this technique. The highly magnified inspection, you can see the branch of the STA and coagulated appropriately and harvested and successfully. Usually I harvest about 6 or 7 centimeter is sufficient for this surgery. And the small craniotomy, you have to do a small craniotomy performed, and the dura was opened, and the recipient artery can be identified. And the pinkish recipient artery, good candidate, good recipient. Some reddish is a very, very symbol, is not sometimes difficult to smooth for the bypass surgery. So the edge was STA, the cutting edge was trimmed, and making a Fishman's training. The recipient artery clamped, and the insides they're washed, rinsed the recipient artery. And what is important point at this point, we should confirm the lumen of the recipient artery and the donor artery. Inserting the needle, you should lumen of the recipient artery. The needle should be inserted outside, inside. So, of course, inside, outside. You should, during this procedure, you should mind in your heart, outside, inside, inside, outside, every time, if you not get accustomed to doing this surgery. Inside, outside, okay, every time, every needle insertion, you should confirm the lumen. Lumen is very important. Appropriate course. You can also always confirming the appropriate course is running, the needle is running with the appropriate course. Always confirming. After declamping, it takes about 20 minutes for this surgery for clamping time. This is a branch of the STA, not the anastomosis portion, as coagulate. Don't coagulate the anastomosis portion. I just coagulate the branch of the STA, small, tiny branch. And the ICGB angiography demonstrated patency of the graft. The postoperatively, there is no hemorrhage. Sometimes patients may occur postoperative hemorrhage due to the hyperperfusion, but you should take care of the postoperative hypertension to avoid the postoperative ICH. And this craniotomy line and the MRA demonstrated graft was patent, and their SPECT study demonstrated the increase of the cerebral blood flow at the operated side. And I talk about briefly regarding Moyamoya disease. And this is a 17-year-old female and woman, and the right side ischemic region was already suffered, and the bilateral ICA terminal portion was typical finding for the Moyamoya disease, and Moyamoya disease was identified on the angiogram. And this is the ECG. You can identify that both STA can be available for this surgery. And the SPECT study, I demonstrated the right side is more severely disturbed. And as first I choose to perform the right side surgery first. And in this Moyamoya disease patient, we do not only the double barrel anastomosis, STM-MC bypass, but also the indirect devascularization, encephaloduro-myoarterial pericranial stenosis. Also, we have to perform. The skin student like here, and both ST graft was harvested under the microscope. And so as I mentioned, using the bipolar cutting technique, the skin flap was reflected, and the temporal muscle and temporal fascia and the pericranium in the frontal region was also to be used for this surgery, including the portion. The both STA was harvested appropriately and anastomosed appropriately. As I mentioned, in every needle insertion you should care about the lumen. You should watch the lumen of the recipient artery. The first anastomosis was completed, and the second I launched to the second anastomosis, and the pyoctanin dye was used to visualize the cutting edge well. And after the anastomosis, and two ST graft was patent, and the dura was inverted surrounding dura. Subdural area, and you can see the temporal muscle and the first frontal fascia and the pericranial fascia was covered over the brain to accept the as indirect devascularization. Of course, both post-operative, no hemorrhage, no infarction occurred to the patient, and both bypass graft was patent. In training, in your institute, you can perform the training bypass surgery. If you have the chance to have the artificial vessel, you should artificial vessel placed like this, and the donor artery can be placed like this. And the edge was 60 degrees cut, and the same lengths were cut. And I call this Fishman framing. And the length of the incision line for the recipient artery should be same as the donor artery. And first, I should perform the state suture 12 o'clock position and 6 o'clock position. After that, you should insert the just adjacent to the state suture, and the drop suture using the tensile nylon in order later on. And needle insertion point is very important. From the edge should be the same as the wall thickness, like this. And the interval of the stitch should be twice as the blood wall thickness. This is just an estimation. But this, as I mentioned, this far away insertion is advantageous inverted to the lumen. Platelet aggregation may occur postoperatively. So this is my training kit using the artificial vessel like this, and after your daily surgery, before returning to your house, once again you should return to the operating room and training like this with your fan. You should try, and if you don't have the artificial vessel, you can try using the chicken wing like this. Chicken wing have the ulnar artery, radial artery, every chicken wing has. So you can harvest both artery, and you have just only a microscope or just a scope. You can try this bypass surgery. You can training in your institute like this. So this is the take home message from me. For safe and reliable bypass surgery, the lumen must be properly checked, and the needle must be passed through all layers. Create bloodless surgical field for full visibility of anatomical structures. The frequent training by yourself is mandatory to become a good bypass surgeon. Thank you for your attention.
Thank you. Thank you very much, Professor Kimura. Thank you very much. This is very good and perfect way to explain to the young neurosurgeon, but also to some senior neurosurgeon how to make the bypass and their indications. I would just two question for a beginner, a young neurosurgeon resident who want to learn this technique. How many patients should he do before he can have what the learning curve, and how many cases in the laboratory and to go to surgery? What is your experience?
Thank you for your question. Good question. So no training limitation. I don't think about it, but at least every resident should perform this bypass surgery using the chicken wing within the 30 minutes or 40 minutes to complete this procedure or suture. Maybe I think, yeah. More than one hour, it takes longer than I expect. Less than 1 hour, less than 40 minutes is good. First trial for the actual surgery, I think. Thank you.
Okay. Thank you. There is any question from the comment?
There is a question. Yes, after you raise your hands.
Hello, good evening to all the respected professors and greetings to all the neurosurgeons from around the world. I have one question, Professor Kimura, and that is, how do you determine the target vessel or the point to which you bring the graft to? What kind of preoperative imaging modalities do you use? Thank you.
Thank you. It's a good question. So did you mention regarding how to select as a recipient artery preoperatively? Recipient artery.
Exactly. Yeah.
Okay. Thank you. So maybe it's a great problem. So if you have a good resolution CT angiogram in your institute, CT angiogram can you evaluate appropriately the thick recipient can be identified on the brain preoperatively. But very small, tiny recipient cannot be identified. If you can identify the CT even on the CT angiogram on the operated side of the brain, you can preoperatively identify the cortical artery on the CT angiogram. It is maybe a good candidate for the bypass surgery. Of course, after the craniotomy, you should choose the pinkish recipient artery, not red recipient artery. Red artery is very thin, is very fragile, like a moya patient. If you can choose the pinkish artery. Thank you.
So is there also a situation where you have to improvise and choose a new location from the preoperative imaging position?
Yeah.
Like due to the optical weight. Sorry.
Yeah. Sorry. We can choose the CT on the CT angiogram. We can choose the recipient artery appropriately. Yeah. Okay. Just using a CT angiogram, and you can find out a good thick recipient artery on the CT angiogram.
Okay. Thank you, Sensei.
Thank you. Thank you.
And Professor Prisha, do you have any comment?
Thank you, Professor Kimura. It's very interesting and controversial operation, and thank you very much. It was have good learning points, but it's still a controversial issue of neurosurgery. Thank you very much.
Thank you. Thank you. A little bit. Some point is controversial, maybe, as you mentioned. Yeah. Thank you.
Yes. Kimura Sensei, thank you so much for your lecture. And, actually, as suggested by you, I get my chicken wing ready.
Good training kit for you or us. Yeah. keeping in a refrigerator in your hospital. Yeah, every time, any surgery can
I get it.
perform. Yeah, thank you.
My 2 days portion of chicken wing.
Great. Yeah, good. Yeah, you should recommend your younger new surgeon as you do. Yeah, thank you. Very important point. Training is very important. Of course, when you encounter emergency case, unexpected, you can encounter the emergency patient. At the time, you should perform the bypass surgery.
Yes.
Preparation is very important. Thank you. Good.
Okay. So if there's no more question, maybe shall I invite Epithema to say the final words and also Professor Kato to say some final comment.
Okay, thank you very much. So it was great lectures. And thank you very much, El-Habib, the MC today. And I think Dr. Cablo, he is now with me. He attended the clipping and the bypass or microvascular decompression on the endoscope, and sometimes he visited the several institutes. I think that he learned a lot. Every night he trained the bypass, just like Kimura Sensei showed us. Once he finish the training, every night send me their pictures. So day by day they improved. Day by day they improved.
Very great. Good.
So, yes, I think even they do not have anything at the moment. Maybe the Cablo would be the first clipper in his country, I think, once he go back to the country. So maybe we will have some hands-on workshop or some conference with the Congo countries, I think, in the future. And also, the Vietnam is another very important country. And Dr. Hay, thank you very much for a nice presentation. And your step-by-step the ETV was very valuable for the young doctors. And we have again, I heard, because it's some limitation of the live surgery in the country, maybe in the future, maybe we can do some the hands-on or the conference, even without live surgery. And also the Sandeep, thank you very much for the nice presentation with anatomical point. So anatomy is very, very important. In Japan, also the less chance for the YNS, the cadaver dissection course, but some many problem. And I think anatomy is very important for the high grade surgery. So I think the YNS should learn every day the anatomy. It's very, very important. And finally, the Kimura Sensei showed us a very nice presentation about the bypass. I think,
Thank you.
maybe in future, I think most of the clipping surgery, the aneurysm treated by endovascular, already the El-Habib that he mentioned, even the tumor cases are treated by radio surgery or chemotherapy, etc. So maybe and also the endoscopic procedure will taking over, I think, direct surgery. So the less and less invasive treatment for the patient and also for the surgeon in the future. So I think bypass surgery will remain for the next 5-10 years, I think. So congratulations, Kimura Sensei.
Thank you. Thank you for your support. Good support. Thank you.
Yeah. So please continue your brush up your skill.
Thank you. Thank you very much. Yeah.
And thank you very much, Alexander. His two students will arrive in Japan in 2-3 weeks. Will very much exciting to welcome the 2 doctors from Ukraine. So maybe the Cabro and the current our fellow will maybe the few days overlapping with them. I think they can share the knowledge and or exchange the information each other. So and also Howard, thank you very much. Always you assisted our educational activity. And still some problem. We want to transfer some shunting system, but still some problem. It's quite difficult to block at the airports, I think. So anyway, thank you very much for the nice the webinar today. Thank you very much.
Thank you. Arigato. Arigato gozaimasu.
So Dr. Ben.
Yes, so thank you so much, and we all have a very fruitful night tonight, and a very wonderful lectures and discussion for our respected speakers and also audience. So we shall end the session, and I want to say goodbye to all of you, and please come to our next webinar as well, and we will keep this going and going to surgeries. And so to say goodbye, so we will also have the board meeting later on. So for those who are attending the board